Yeah.
You just blow up your house.
Right.
You just light your house on fire.
But what about the ones you missed?
Yeah.
Well, I don't know. Who did we miss?
Yeah.
Show me.
You are listening to EMS with your hosts, Erik Axene and Matt Ball.
Well, this is a good topic I think we're going to talk about today.
Well, all of our topics are good topics.
Well, you know what I like about this one is that like this one is one of the ones that it really does. It's a tangible way to really save lives and decrease mortality. Mm-hmm. Hospitals really care about this, and so they rely upon us in the first responder community to be able to be on point with this topic.
Early identification is key, just like with the STEMI or with strokes. We're finding out that we have an impact here.
Big impact.
Yeah. So make sure you like, share, subscribe to our YouTube, make comments, and like we've been talking about, you can get CE credit if you are on our website, Axene.
CE.
I can't even talk.
AxeneCE.com.
Yeah.
Yeah, if you want CE credit for it, which you can. CAPCE accredited credit for these things.
That's right. Yep. 30 minutes at a pop. You get a credit. But you got to do it through the website so you can get the certificate and take the quiz and do all the things that they require you to. We get asked all the time, why can't we fast forward stuff? Because they won't let us do that. Like, you know,
there's rules.
There's rules. Yes. Yeah. Everybody, they want to find that CE provider that they can just go to the end. Like, no, bro.
Yeah, death by PowerPoint stuff. I can see why people want to fast forward because
100%.
We owe people that professionalism to be able to.
That's right. Hopefully, you enjoy listening to the podcast, and now you can get CE credit
and learn something. Really improve your practice,
right?
Or
and
reinforce good stuff.
This would be one of those things. Mm-hmm. So sepsis. Hot topic.
Mm-hmm. What is sepsis? How would you define sepsis? Well,
go ahead. Oh, you said well. You want me to define it?
Well, I mean, I think we both talked about this.
Yeah.
I mean, it's really less about the infection.
Right.
It's more about the body's response to the infection. We have a foreign invader that gets into your system, and then the system recognizes it through the immune system. Massive inflammatory response with these deadly chemicals called cytokines and chemokines, all sorts of. We could geek out on that, but we're not going to.
Well, you're not going to.
No, you won't let me. But we don't need to know that.
Right.
That's one thing I like about the way we work together. It's we don't need to know that, right?
Right.
I need to know as a physician what we really need to know, and you're the expert there. And then sometimes it's good to know some of the geek out stuff. It's like, why do we do this?
Right.
Oh, that's why.
I think you can give enough information about how it's working.
Yep.
Right, so that you understand the basics of it, but you don't have to get down to the cellular level to understand how to identify it, what to do about it, all those kind of things. You don't have to. I mean, it's interesting. Yep. Like I find that interesting, but not everybody finds what we find interesting.
Well, I'll tell you this, and this is the common thing with all disease processes. Is right now when you're in a state of health, there's this idea of homeostasis where things are in balance. Mm-hmm. And things are constantly changing, and things are challenging that sense of balance, whether it's thermoregulation, where it gets cold, so you put on your jacket, or
pH levels.
Correct. You don't eat enough, and so you break fats down to maintain that energy balance. And if you eat too much, you store it to maintain the energy balance. I mean, the body is constantly trying to maintain homeostasis. So when you're in a situation where you have an infectious organism enter your system that's not supposed to be there, and then it takes root and multiplies, and now it's starting to cause dysregulation to your body system, you get sick.
It's kind of like if you think about you got your house, right?
Yeah.
And you're trying to keep your house protected, right? You want homeostasis in your house, right?
Yep.
Everything's at peace, everything's clean, organized. At least in my house, I like it to be. Yep. And then you get an infestation of bugs in your house, right? Oh. Well, so the sepsis response would be you have an infestation of bugs in your house, and instead of hiring a insect guy to come in and kill that thing, you just blow up your house.
Right.
You just light your house on fire. That would be an overreaction.
Yeah, and that's what happens with sepsis.
Exactly.
Is that the response to this infection is way overreaction.
Right.
And some people are worse than others.
Yeah.
So the interesting thing is, like with bacteria, for example, like like a staph infection, from maybe a skin infection, you get cellulitis or something like that. If that gets into the bloodstream, those organisms release toxins that cause the blood vessels to totally go wonky on you.
What's it called? The glyco?
We'll just call the inner lining, the endothelial lining is actually really important to the function of a blood vessel, because on the outside you've got these smooth muscles that can cause it to vasoconstrict and vasodilate, and that helps us to maintain blood pressure and perfusion of organs. Right. You throw a bunch of toxins from an infection, now they're all dysregulated and the blood pressure goes down and organs don't get perfused, and that's what kills people.
That's right.
There's a progression of sepsis from you screen positive with some bad vital signs, which could be a sign of compensation, trying to get back to homeostasis, right? And then if you find a source, bad vital signs plus a source equals sepsis.
There you go.
And then when sepsis gets to the point where organs don't work, you go to severe sepsis. You get to low blood pressure, now you're in septic shock.
That's right.
And then when you get to the point where multiple organs start to fail.
Altered mental status.
Yeah.
You start getting wanky.
And then MODS, right? Multiple organ dysfunction syndrome. So that's the bad stuff. That's the STEMI of the sepsis world, is get to MODS. And I didn't know this, but when I lectured on sepsis recently at a webinar with EMS World, no, I'm sorry. This was at ESO. Conference, getting confused.
Yeah, you've been all over the place lately.
I talked about the mortality rates of sepsis, and I asked people, of these 7 things, what's the most life-threatening? I'm going to see if I can remember them. Did I talk to you about this?
No, I don't think you talked.
Oh, this is interesting. Okay, this will be a fun little bird walk here. I think we're on track. I think we're okay with time.
Go for it. Yeah, I like it.
All right, rattlesnake
bites.
Rattlesnake envenomation, not a dry bite.
Yep.
Plane crash.
Okay.
Commercial or private.
Yep.
What's the highest mortality rate? That's what I'm asking. Gunshot wound to the head.
Oh.
Fall from 60 feet. Sepsis, multiple organ dysfunction syndrome. Shark bite, unprovoked. And there's another one I'm missing. I think I got 6 of the 7 there, but it's not important. So of those, which one do you think is the least lethal? Gunshot wound to the chest was the other one.
Oh, head and chest.
Head and chest.
Okay, so 2 different categories. Yeah. Okay. I would say the least lethal would be the snake bite.
That's correct. Okay. Yeah, less than 1%.
Yeah.
We played with rattlesnakes.
Yeah.
It was scary, but
yeah.
we were.
Yeah. Nobody wants to get bitten by a snake, but yeah.
It's like a fear.
It's not going to really kill you most of the time.
And what's the most lethal of all those?
Well, golly,
if you remember,
a gunshot wound to the head. I would think.
No, it's not.
It's
not. 90% mortality rate. Okay. 90%. So 10% of people can survive a gunshot wound. If you look retrospectively,
really?
I thought that was interesting.
Yeah, I would have thought.
Gunshot wounds to the chest.
I mean, I guess it qualifies what they're talking about. Like, are we talking about a grazed gunshot? Kind of what are the categories?
Based on the data, gunshot wound to the head, all gunshot wounds to the head, 90% fatal.
Okay.
I
thought it was higher.
100% of people who fall from 60 feet die. 40 feet, it's 50%.
Oh, that's right.
I think it was 40 feet, it was 50 or something like that. Or no, 75, and then 20, I think, was 50%.
Okay.
But you get to 60 feet, the terminal velocity, you're done. You're not going to live when you hit the ground like that. Just the massive deceleration. But what I thought was also interesting is mortality rate of sepsis, of MODS, can be worse than a gunshot wound to the chest. Gunshot wound to the chest is around 75%. Okay. MODS can get up to 80%. So that the point, and the reason I did this was to illustrate how deadly. Oh, plane crash, by the way, was the second least likely.
Well, yeah, because it doesn't happen.
Less than 5%.
Is that of people that have been in a plane crash?
All plane crashes. All what is the mortality rate like of?
Okay. Well, I guess that's because
if you're in a plane crash, how likely are you going to die?
Well, yeah, I guess it depends on what they're defining as a plane crash, because we get planes out here that
it's all plane crashes.
That's what I'm saying. A little Cessna does a belly landing. Do they call that a plane crash? If you're in a 737 falling from 30,000 feet, you probably don't have.
You're not going to. Yeah, that's true. But that happens so rare, though.
Right. Exactly.
Like the plane crash we recently had in Toronto. I actually talked to the Toronto fire chief about this. He was helped with care for these folks, but nobody died.
Nobody died.
Nobody died. They crashed a big plane, hundreds of people. Nobody died, and it was because of the snowbank. The snowbank ripped a wing off, so they didn't have all that gas.
Yeah.
Otherwise,
it
could have been much worse.
Or like you got Captain Sully. landed that
Yes,
down the Hudson.
right. See, I'm talking about.
Dude's
So
a hero.
But anyways, the reason I brought this up was to illustrate how a gunshot wound to the chest, comparable mortality rate to MODS.
Right.
That's crazy. And a gunshot wound to the head was not as lethal as falling from 60 feet. I thought that was interesting.
And people ask why. We talked about this in another podcast about, why are we giving antibiotics? I had the guy ask me this question, and he was just being genuinely curious. And it's like, well, why do you give blood to trauma patients if you have that ability, or why do you, whatever? Because you're going to save their life by doing it. And 80% of these patients in septic shock can die if you don't. That's right. Yeah, so it's very important.
Yeah, and when we get to management, we'll talk about how important the management is by doing that early. But the disease, I think we've covered the disease. We could have geeked out on it even more.
Right, and people have heard about sepsis. They understand. Yeah. Obviously, you have to have some sort of an infection. I would be curious to know, I would think UTIs is probably the most common cause of sepsis.
Good question. 95% of the infections are either skin, bladder, or lung.
Okay. So
there are pneumonia, you could have bowel, you could have
there's lots of different
like
ways.
Meningeal infections and things like that. That's like neuro infections, like meningitis.
Right.
But the common ones would be bladder, lung, and skin.
Yeah,
and skin would include throat, include ears, and kids, all those things.
Right.
So,
yeah, it seems to me most of the ones I've had pre-hospital would be either pneumonia, or most of them have been UTIs.
Yeah.
It seems that's where it kind of originated.
Yeah.
All right. So presumed source of infection is a big indicator.
Huge. Yeah.
Right?
And then the body's response to that is really what creates the problem. That's what killed people in COVID. During COVID, people weren't dying necessarily directly from the COVID virus. It was the body's response to it that killed people.
We'll just leave that one. Yeah, we won't get into that topic.
But the body's response, the host response, is really the big part of what kills people and what makes people real sick. Is the fighting against the pathogen.
Right. Blowing up your house for the ant hill. Just think of it.
Right.
Overreaction.
Very deadly, potentially. So, which kind of leads us to the next, kind of topic within a topic. And I think I would say the most important thing that we could talk about today. Yeah. Management's important too, but I think this is clearly the most important thing.
Well, and you're saying that based off the data that you found.
Right.
Is it nationally? We're missing a lot of... Yeah.
We're missing a majority of these sepsis patients, and we're misdiagnosing them. They're not getting the identification, the early identification, which really saves lives. So that's it, as assessment.
Yep.
And that's a big part of what we do in all diseases, is identifying a disease process.
Yeah, but doctor, they say that we don't diagnose as paramedics.
We do, don't we? Isn't that crazy that people would think that? But
how do you treat something you don't diagnose? I've never understood that.
Right. We don't make the official diagnosis.
Right, exactly.
That's right. But we have to put them into the right bucket. So the treatment that we offer gets to the hospital, and then oftentimes in the hospital that diagnosis sticks to the patient and brings them into the hospital admitted. And if it's the wrong diagnosis, they may not find out for the next day, which delays care for really ultimately what's causing the problem. Right. So I think assessment of our patients is really important. And it doesn't sound sexy at all.
Nope.
But early identification is what saves sepsis patients' lives.
Excuse me. Yeah, and so we've got like the SIRS criteria, which you are not a huge fan of.
No, I'm
just
not.
Not very effective based on data.
It's good. It's good for what it does in trying to catch everybody.
It's more of a shotgun approach.
Well, this patient meets sepsis criteria.
Yeah, their heart rate's above 90, their respiratory rate's above 20. And you got to look at it, and it's like, okay, well, what's the context, though?
And one of them is a blood test. You don't even do it in the ambulance.
Yeah, right.
And of the studies I read, of 18 of them, only one of them even studied the pre-hospital environment.
Yeah.
So QSOFA, the modified QSOFA, is a little bit better. It's definitely better than SIRS for identifying sick patients. And that involves organ dysfunction because you got the ultramental status in there. Right. Clearly, a fast heart rate, that's a way we can see that on the monitor. Right. Why is the patient's heart rate so fast?
Right.
Why is the patient's blood pressure so low?
Right.
Gosh, is there a cardiac thing happening?
Right, you do your due diligence, right? You put them on your EKG, you run a 12 lead, you ask about history.
Correct.
And then in your history, if they say, yeah, I've had an MI in the past and I'm having crushing chest pain, I'm going down the cardiac route.
Exactly.
Where they say, she's a little bit altered, grandma's a little bit altered, and then you ask, because you're a smart paramedic, you're like, She had a UTI recently. Oh yeah, she's got diagnosed 2 days ago with a UTI. She been running a fever? Yeah. Okay, now I'm going down the sepsis route. Yeah.
Is that part of your vitals? Did you get the temp?
Yes, you should get a temp, but don't always. I get people that tell me that, well, they didn't have it. They were afebrile. It's like, okay, just because they don't have a temp doesn't mean that they don't have an infection.
Exactly. Get the temperature. If they don't have it, it doesn't mean they don't have. I mean, it's like EKGs. Just because there's no STEMI there, it doesn't mean they're not having a heart attack.
Yeah. And most of the time, I mean, like, you want to get the number for your documentation. That's important. Right. But you can tell, like, I go out and I'll touch these patients, like, holy cow, they're burning up. Yeah. Like, you can feel it. They are on fire. They got a fever.
And we have to be careful, too, because if you talk to your patient and you ask them, hey, have you felt hot lately, or have you felt like you have a fever?
No, I got the chill.
The chills.
Yeah.
When our temperature goes up, we feel cold.
Right.
Because we're trying to absorb temperatures, the temperature deficit. So we feel cold because we're trying to absorb energy. Right. That's why we feel cold and we want the blankets. Yep. Our body's trying to raise the thermostat.
Yeah.
And so if a patient is asked, have you had fevers? No, the opposite, doc. I felt cold. And that actually is a bad sign. Yeah, so you're right. Clinically, that would be, to me, more concerning than a temperature that was maybe 99 and 99.9 or whatever. It doesn't quite meet fever, criteria. It's not over 100.4. Yeah. But the history of the chills is a big deal. So it's not just heart rate. It's not just blood pressure. It's not just all these signs and vital signs we'd pick up on our Life Pack or the Zoll monitor or whatever, right? Mm-hmm. There's also the mental status.
That's right.
That's the first thing to go. Why is the mental status the first thing to change? Do you know why?
I mean, I would think the brain is so dependent upon oxygen and glucose, right? And it's so sensitive to changes in oxygen and glucose levels that with all that overriding response from the host that we talked about, that you've decreased the oxygen and glucose levels in the brain, and so you're getting...
It's the most sensitive cells in the body. It's like a canary in a coal mine. When you have the patient that gets altered, that's usually the first thing to go because the brain cells, like you said, are so sensitive to deprivation of oxygen. They need it all the time. Yeah. And if they don't get it, grandma's acting weird.
Right. I think the other vital sign that we need to talk... Well, first off, two things. You talked about heart rate and blood pressure, but there's something we can do with our heart rate and our blood pressure that we'll talk about in a minute. Yep. And then end-tidal. End-tidal has proven to be huge. And as pre-hospital providers, we are really on the cutting edge of using end-tidal for sepsis. I specifically have brought patients into the hospital, one specific patient I can recall that had a very elevated heart rate, but that was it. She had no temp. She did have maybe a little, they said maybe the flu, but she had an obvious infection that we found, but her end-tidal never got above 19. And I'm like, oh man, she is septic. And the doctor didn't believe me. When I told him, I was like, hey doc, and he's like, well, why'd you call sepsis on this? I said, well, this, and this, gave him the whole story. And I said, and her end-tidal was never got above 19. I had her on end-tidal for 15 minutes. So as EMS providers, like we've talked about with our OMI stuff, we're on the cutting edge of this end-tidal stuff, and we can help educate people on it.
And in the hospital, if you were to shadow me, we're going to be waiting for that lactic acid to come back because that's one of those measurements that the hospital watches to trigger sepsis. And when somebody has a lactic over a certain number, it triggers all this hospital monitoring thing for sepsis numbers. Yeah. So the lactic acid is huge. And so we have the surrogate in the ambulance. Mm-hmm. The end-tidal less than 25. This correlates with the lactic acid of over 4.
Right. Which is indicative of septic shock.
Correct.
Right.
And that septic shock is the beginning of what could become MODS if we delay care.
That's right.
And, I think as far as assessment goes, the last thing I would say is that you want to be really careful with certain patient populations. Mm-hmm. If you have a patient that's on chemotherapy or some sort of an immunosuppressant, your trigger for sepsis should be higher. Pregnant women, little babies, less than a year old,
nursing
older
home
folks.
patients.
Yes, right. Yep. Those are populations that are particularly at risk for becoming septic, and they can get sick if they get missed.
That's right.
So you get there and you think maybe they're altered and you're thinking stroke for some reason, and so they get bucketed as a stroke patient.
Which I don't get. Altered mental status is not a sign or symptom of a stroke. Yeah. They're altered because they can't talk, right, maybe. Right. But they're not altered. Yep. Altered mental status is they're looking at you, they're trying to talk, they're confused. Yep. It's an altered mental status.
It's kind of a generalized thing. Yeah, whereas the stroke is usually unilateral, something asymmetric.
Right. Yeah. You're going to see some drooping or they're aphasic, something like that. I don't consider somebody that's because you can tell with a stroke patient, they're still tracking tracking with their eyes. You can tell they are understanding everything that I'm saying that's going on. They just can't respond to it.
And the sickest ones, I think, are the ones, we're not talking about stroke today, but the LVO, the large vessel occlusions, they're staring off to the wall.
Yeah, exactly.
And you're over here talking to them, and they're just looking over here. They're looking all over, trying to find you, this voice thing here.
That's right,
Those are the bad ones.
But see, I don't look at, that's very stroke-like. To me, stroke and altered mental status look very different.
And I think what's happened, though, is that people can have strokes with all sorts of different symptoms, and then we miss one, and you get your hand slapped, and then you're like, well...
I'm not doing that again.
Right.
So what do we do? Everybody's having a stroke.
But see, this is what's happening with sepsis, though, is that people will go see a patient. Here's a true story. I was on a ride out with my paramedics, and I smelled the urine when I got in the room, and I saw the leg bag on the patient's leg under his pajamas. Wife says he just got discharged, treated for UTI.
Red flag.
Guy's got a fever. Guy's tachycardic with AFib RVR, actually. His blood pressure was kind of hanging on a balance, just really not so good. And I told the patient, my paramedics, like, guys, this is perfect setup for sepsis, right? And as we continued to assess our patient, we saw some blood around his mouth, some dry blood. Wow. Hemoglobin ended up being 5.
That was bleeding.
And so he had a GI bleed. That's what I thought the big thing. So I remember on the way back in the ambulance on this ride, I was like, guys, see, I even anchored on sepsis, you know? And it was really probably a GI bleed.
Were the other signs there, like elevated heart rate, which would be hypotension, certainly?
Pale conjunctiva. I went through the whole thing on loss of palm creases.
Interesting.
But I want to share the story because I was wrong. You know, the patient, I got there and the PA, his name's Justin, he told me, hey, the patient hemoglobin was 5. That's probably what it is. We're going to admit him to the ICU for transfusion and all that stuff. And that's a big part of sepsis, too, is having the hemoglobin there so you can carry the oxygen. If you have a low hemoglobin, it's really tough to make yourself better.
Doesn't matter how much oxygen you're breathing in. You don't have enough trains to carry it.
And so getting your hemoglobin at least up to 10 is a really big thing for patients, beyond the 7, but to 10. Anyway.
But it's like, you weren't wrong, though.
Well, I was, though.
But that's the difference.
It wasn't hemoglobin, though.
Well, yeah, but you had no way to know that.
Third diagnosis.
Oh, you did what?
Third diagnosis.
Oh, it wasn't the hemoglobin.
I was wrong. And so the reason I tell this story, though, just to encourage that. I'm a doctor, right? And I thought for sure it was sepsis.
Sure.
And then I saw the dry blood around the mouth, and so now I'm anchored on GI bleed.
I thought you didn't find this out till you got to the hospital.
Well, it was confirmed at the hospital, so I thought I was really right. I get a call on the way home. In the ambulance, got a call from Justin again. It's like, dude, the CT scan just came back. Necrotic appendicitis. And I remembered on the way there, every bump we had on the road, the guy was swearing when he hit the bump. And I'm like, and I did a belly exam. He wasn't tender.
McMurray's point or whatever.
He'd had this necrotic appendix for who knows how long, but it just got to the point where it had really overrun the body's regulatory systems, and it wasn't the UTI. It wasn't his anemia.
So he wasn't septic. He wasn't. I mean, he was anemic, right?
Well, true, and all these things could be true. It's just the thing that was most life-threatening. The thing that was going to kill him the quickest was going to be getting that colon out. Right. He had a necrotic appendicitis, and it was really nasty on the CT scan. And if they would have delayed care on that, it could have been deadly.
That's important to again. You anchor. We talk about it all the time. Don't anchor, right? And you're going down the road and you're missing this obvious. Every time you hit a bump, you're missing that because you're like, this guy's septic, and you're doing your report and you're not paying attention, right? That's pay attention to those little things. Like, why is he jumping every time we hit a bump? Like, what's bothering you? What's hurting, right? If they can respond to you. But that also goes back to the fact that in the pre-hospital, we don't have access to run hemoglobins and get all these things. So,
but I should have laid him back. And I should have done a thorough belly exam. Is what I should have done. He was screaming out to me, literally with profanities, telling me I have an appendicitis.
Oh, he was telling you that?
Well, I mean, his actions
what he was
were,
doing. Yeah. I thought you were saying it's like,
shut up,
idiot!
I'm trying to tell the guys about your anemia.
Shut up, Mr. Patient. I'm a doctor.
Well, we all have the risk of anchoring, and I'm just being honest. And the guys, it was really cool too, is learning for them because they see their medical director saying, "Oh, guys, I kind of messed up,"
You're human.
I mean, it's a mess up, but I had anchored on the blood. Yeah. And I made a point about not anchoring on the sepsis.
What was the shock index?
Shock index would have been terrible. His heart rate was in the 170s.
Okay, so
and blood pressure was low around 100. So that's pretty low.
Yeah.
That before we close out, I guess part one of sepsis, let's talk about shock index, because that's better than just looking at the heart rate. I mean, looking at the heart rate and the blood pressure together, I think it's a pretty powerful tool. And it's actually part of a screening tool that I think is the best one, the SMART, S-M-A-R-T, SMART screening tool. So
I'd say let's take a break, and we'll come back. We'll talk about SMART, and then we'll talk about management of septic patients.
Perfect. And then the future of sepsis management.
The future. Get excited, folks.
I'm excited. Be a futurist.
Uh-oh, he's excited. Here we go. That's not true.
So we ended the last one. We were talking about sepsis. We talked about the
finish
disease.
Up with shock index.
Assessment, which, again, is the most important part
of
what we do in the pre-hospital environment, is identifying disease accurately.
And we're saving time in the hospital because we're doing our due diligence and we're getting all this evidence together to say, this is what I think is going on with the patient, giving it to you at the hospital so that you don't have to waste time doing all those things.
Right, exactly. And I think, and a lot of this is going to come out in our last part when we talk about data, but
data
is when we identify somebody early. They have early treatment, and treating somebody earlier is better.
Yeah.
And data may not show some things when you look at it from one perspective, but I think I'll make a pretty good case for it based on the data I've read. That I think we've got a great case for early assessment and management.
So you talked about SIRS is not great, QSOFA is a little bit better, but at the end we were going to talk about the SMART criteria.
Correct. And there are other ones too. And then in the last part with some of the other future stuff, and some very exciting things happening right now in this very field in sepsis screening. But I think, in my opinion, the best one that we have is kind of complicated, so that makes it maybe not so good.
Yes.
The SMART, S-S-M-A-R-T.
Which most people probably go through it because they probably don't know it.
So for me, that I do like a lot of it, but I think that QSOFA is so simple, and it involves organ dysfunction, which SIRS doesn't. To me, the QSOFA is maybe the way to go.
Pre-hospital.
Yeah. And like I said earlier, there's no studies really that really focus on the pre-hospital environment. There may have been one out of 18 that I looked at that considered that. No. Observational, retrospective studies. And it's tough, too, to really get a good blinded, randomized trial that, gets that real, that perspective that studies something in longitudinal kind of perspective, looking ahead. Right. A lot of what we do is we look out the rearview mirror, and we're trying to find correlations. Less causation.
Right.
Causation to me that's really where it's at, and sometimes it's hard to do it. It's hard to get the IRB approval for that. But based on the data that we studied, there's really no great assessment tool that's really doing what we want. And if you look at the sensitivity and specificity, it's kind of like the quality of predictive value of a test, of screening tools, of things like QSOFA and SIRS. I mean, the sensitivity and specificity is pretty poor when you compare it to some of the other screening tools that we use. Like a good sensitivity might be 99%, right? Which is good for ruling out people for a screening tool. But when you start to look at the sensitivity and the specificity of SIRS and QSOFA, you're getting down into the 50s. That's like a coin flip. So we got to be careful with these. But we don't have a great tool yet. So it's tough. That's why this is so important, is to look at your patient. Don't forget to get that temperature.
Temp, history, heart rate, respiratory rate, end-tidal, right? Is there a presumed source of infection? Do they look sick? Are they altered? That's a big indicator. What's their SpO2 at?
And what are the risks?
Yeah, what are their risks? Yeah, exactly. Like you said, are they in a nursing home? Are they elderly? Ask. History of UTIs. Have they been in the hospital recently? Maybe they have pneumonia, right? If you put them on oxygen and their SpO2 is not coming up, that's not good, right?
No, not good.
Their blood pressure, you're giving fluids, their blood pressure is not coming up. All these are signs that are pointing you down the sepsis route.
Yeah. And there are a lot of things that can make a patient altered. It's just one of the common ones is sepsis.
It's context.
And here's another thing that kind of back a section here, but Do you know that the most expensive thing that the hospital treats is sepsis?
I would think just because of the sheer number.
The sheer number, yeah, that's true. But also the leading cause of death in the hospital, too.
Yeah.
This is a big deal disease. A lot of people die of infections, and it's very expensive.
Yeah.
The other thing that we really haven't talked a lot about, but when you identify somebody early and you start treating them early, they become less complicated, and less complicated patients cost less money.
Hence why we start giving antibiotics pre-hospitally.
Right.
Because it's helping globally the patient problem or the sepsis problem. Right. Not just helping the patients, but helping the it's a global somewhat of a remedy. Right?
And if you identify them early, I think it's a good transition now into management, right? So early identification, early treatment.
You've got all the signs and symptoms of sepsis. What are we going to do with them?
So how do we, you've identified a patient. You're at a nursing home.
Yep.
Actually, I remember the
patient we were together.
We pushed some pressors, I think, on that lady at that nursing home. And so when you've identified a patient as being a potential sepsis patient, you've gone through your protocols. Maybe you're using SIRS or QSOFA, high heart rate, low blood pressure, febrile, slam dunk. This is probably sepsis. Don't put your blinders on because it could be something else. Don't forget to get that EKG when you're en route. It's just basic stuff.
But no matter what, if they're high heart rate and a low blood pressure, guess what, folks? They need pressors. They need a little bit of fluid. They need some pressors.
They need something.
Regardless of what's going on, we got to get that pressure up.
Got to get the pressure up because when pressure's low, organs die.
That's right.
Now, there are some situations where you want to be careful with the pressure that you choose because, if you don't want to whip the horse, if it's a cardiac issue, then you can send the person into, fluid, pulmonary edema. But you're right, though. It's like you see somebody that's tachycardic and hypotensive. We need to support them.
Yes.
What is making it? I mean, is their heart failing, or is it their heart being overloaded, or is their tank low?
That's right.
I mean, who knows?
Vessel problem, right.
So with sepsis, though, I think once we identified our patient in the nursing home, which is a high-risk place to find a sepsis patient, we identified it and we started treating quickly, and she was pretty hypotensive.
She was, and altered.
I think so. I think she was altered, sweet old lady. And so we started early. We identified pretty quickly, and then we started treatment right away. So what are the cornerstones of treatment for our sepsis patients?
Well, first off, is fluids, right? Get your IVs going. Now,
just a little one. It's like a 22 gauge.
Well, so that's the thing. So I've had this discussion with people and medical directors because they're like, 18 gauge. I'm like, okay, bro. I'm picking up 80-year-old grandma from a nursing home. On her best day, I'm probably not getting an 18 gauge in her, right? If I can do that, I will do that for sure. But sometimes, especially if they're in septic shock, you're talking about they got to it's going to be really hard to find any kind of a vein, right? But get the biggest one you can. Hopefully not less than a 20 if you can help it, right? Because a 22 is really not going to do anything anyway. If they're that altered and they're that down the road, you might look at doing an IO. EJ is always an option. Ultrasound.
Have you used ultrasound yet?
Yes.
It's like cheating.
But not everybody has that. Financially, whatever the case may be.
Get the biggest you can find.
Get the best one in whatever way you can find it. Get the biggest IV you can find and start giving them fluids.
That's right. Yeah, fluids. So certainly benefit for fluids.
But they're going away. I don't know if you want to talk about that now or later.
No, we should. Yeah, I think it used to be...
The 30 mL
sepsis, 30 per kilo. How many kilo? 100 kilo. Okay, 3 liters of fluid. Let's go.
It's like when I went to paramedic school. Trauma patients, 2 large bore IVs, pour the fluid to them. And now we're like, whoa, pump the brakes, cowboy. That's killing people.
That's right.
Now we're kind of the same thing with sepsis.
Yeah, so the recommendation... Well, it used to be a recommendation. Now it's gone downgraded to a suggestion.
Yeah.
As of 2023, I think the study we were looking at. So there may be some other data that I've missed in the last couple years, but clearly our reliance upon massive fluid boluses may be causing harm in some patients. So now we're, like you said, pumping the brakes a little bit.
We're not saying don't give fluids.
Right. Definitely need fluids.
Yes. If you're a pre-hospital provider, we're not saying don't give fluids. Obviously, follow your protocols. But and I would even giving them a liter is probably going to be fine. Right. There's no data to show that a liter is going to kill them or anything like that. Obviously, be cautious if they've got CHF or something like that or kidney issues. Right. But you look at your transport times. I got 10, 15-minute transport times. I'm probably not going to fluid overload my patient. If you're rural and you're looking at an hour plus, okay, then you might want to be a little bit more cautious
push those pressors ready.
Have your pressors ready, right?
And that's the indication I've used in the ER for somebody who's non-responsive to fluid therapy. Right. That's when I start thinking pressors. Right. Sometimes I'll even just have the patient ready to go, because oftentimes what can happen is they can tank in the ER even after you've started the fluids. Right. There's this dynamic disease. It can change quickly.
Yeah. Volume isn't always the answer.
No. So volume is good. Early volume, get it started.
Fill the tank.
Yep, and fill the tank, and that decreases the hypoperfusion, which, just so people understand, I think all of us understand, is that when an organ system goes down, for example, the kidneys. So this patient's altered and the blood pressure got so low, the kidneys will actually shut down. They'll hibernate. They're not dead, but they hibernate. They stop functioning as kidneys. They're just taking just enough blood so they survive. And the cellular machinery isn't destroyed by lack of blood flow. And then the problem is, though, the blood keeps pumping.
That's right.
Kidneys aren't doing their job anymore. Right. So now we're not filtering out toxins. We're not managing fluid volume. We're not reabsorbing things properly. And so then we run into some problems with kidney failure. Right. Even though it's temporary kidney failure, we call it an AKI, an acute kidney injury. That actually can cause a cascade of other problems if we don't get it fixed soon. Right. And you start to perfuse right away. It's not like the kidneys automatically turn on. Right. It's almost like they go into this post-ictal phase where they don't start functioning right away.
Yeah, they're groggy. What's happening?
Right. But after a while, though, they'll kick in and then start working. But if we can start treating early and avoid that hypotension, we might be able to keep those kidneys alive or from hibernating, and then we never get to that point with organ dysfunction. Yep. And so you could actually get to a point with organ dysfunction where you just go down a slippery slope to MODS, and then your mortality rate goes really high, like we talked about. But if we can volume resuscitate these folks early and get them started right away, we might actually prevent that from happening.
That's right. And get them on oxygen. Right. Obviously, watch their SpO2, right? But get them on oxygen. Get them on end-tidal, right? If you have end-tidal, please put them on end-tidal. See what their end-tidal is.
And so, good. And then some municipalities, IV antibiotics.
Yep, IV antibiotics. And if they're that altered, look at, just like with any other airway assessment, if they're super altered, their SpO2's crummy, their blood pressure's crummy, you've got them on high flow non-rebreather, their SpO2 isn't coming up, tube these patients. Right?
They may need it.
Get them intubate. Resuscitate before you intubate. Get that pressure up, right? Try to get them stabilized, but intubate these patients, and that could get your pressures, all that kind of stuff. Yeah,
it's kind of it's a scary situation when you get that sick of a patient that's so altered they can't protect their airway.
That's right.
And you've got to breathe for them.
That's right.
And we need oxygen to fight these things. We got to keep the organs perfused.
These are really complicated. A stroke patient, there's not much I can do for those patients pre-hospitally besides recognize, activate, and transport to appropriate. Same with STEMIs, recognize, activate, fluids, nitro, aspirin, oxygen, transport. But a septic patient, you get a really sick septic patient, now you're looking at trying to start IVs on a hard stick patient. You're giving fluids. You're drawing up pressors. You're getting your antibiotics out. You're managing airways. There's a lot going on with these patients. Yeah, that's right. These are the kind of patients I enjoy because they're challenging. They make you think. But
there's some controversy right now with one of the things we talked about, the antibiotics. There's a lot of studies that have said it doesn't help. There's a lot that say it does help, so it's a bit controversial. But I would argue, and I put my medical license on the line with my agency, is that if we can do a good job of selecting the sick ones and use the septic shock patients who are getting the IV antibiotics maybe an hour early or more, that I think is going to decrease mortality. And the evidence proves it. 7% increased mortality for every hour we delay treatment. And treatment was defined as fluids and antibiotics, not just one or the other. So I think that there's some benefit to it, and I think that if you select the right sick ones, because the studies that came out recently, just in the last few months, they only represented about 4% septic shock patients in the selection, in the septic patients they studied. So 96% were less sick. So if you have a healthier septic population, you may not see the benefit.
That's right.
But I believe if you can select the sick ones, the septic shock patients,
the
ones that are hypotensive, with a source, a suspected source,
Right.
I think you'll see the benefit there. The other reason we give antibiotics would be open fractures and things like that, and that's a different
Very
issue.
rare,
but
yeah.
Yeah.
Oh, not super rare, but less rare than sepsis for sure.
And less controversial too, because they're going to need antibiotics.
They're going to get it anyway.
A little bit of controversy on what antibiotics we choose. We use cefepime,
That's what we use,
cefepime, and ceftriaxone's another one, But by getting the antibiotics early, you start to kill those bugs off.
That's right.
Right? And then kill the bugs off, the body can ramp down a little bit.
Return to homeostasis.
Return to homeostasis faster.
That's right, yeah.
And you mentioned pressors. That's another.
Yeah. So you have different favorite pressors. We just have one option. We just use a heavy push dose presser.
Yep, phenylephrine I think was the
that
one.
we just mix and we give it. And then you like Levofed. I know Levofed has been, especially for sepsis, because it's just that potent vasoconstrictor that's going to really help out those septic patients.
That's right. It's good vasoconstriction. It also increases your cardiac output.
Right.
Can help with the push as well as the hoses.
That's right.
So the pump and the hoses. Whereas phenylephrine is the hose vasoconstriction, which can help, but it can hurt too. So it's a good way to get the blood pressure up. But norepinephrine has been proven in multiple trials to be the best pressor, vasopressor for sepsis.
Yeah.
Dopamine, I've read some studies comparing dopamine, but
we going back to the dopamine clock?
Yeah, right. So I think that's the kind of, I think we hit all the buckets.
If you're not using pressors, if you're pre-hospital providers, maybe antibiotics are a little bit controversial. We get that. Maybe your medical director is not comfortable doing that. We get it. But pressors, for sure, and if you carry epinephrine, you can make a pressor, right? There's no reason why you can't use what you already have. It doesn't going to cost you anything. There's a little bit of training on how to do it. It's pretty easy.
I don't know how you do it at your place, but we squirt out.
There's lots of different ways to skin a cat, but you can get rid of one. Exactly.
Follow your protocols.
Follow your well, there's different ways to mix it, obvious, but you're basically taking it from milligrams to micrograms. Right. You're just reducing down the concentration of your Epi 1 to 10. That's all you're doing. And instead of giving 1 milligram, I'm giving like 10 micrograms per dose. Right. And then I'm dosing that. I'm giving them 10 mics. I'm seeing how they do. Right. Obviously, I'm trending my patient. If they're that sick, I'm running blood pressures every 5 minutes.
Right.
What's their pressure now? It's still below 90 or whatever the threshold is. Right. Okay. Let me give them another 10 mics. See how that does. Running fluids at the same time. Right.
And I've done that, and I think actually phenylephrine is one of the ideal ones for like an AFib RVR that gets hypotensive, because you don't want to ramp up the heart rate when you're already high. You want to try to just get the hoses right.
Exactly.
So that's a cool thing about different pressors, and we did a cool lecture on vasopressors, going over each of the main ones and how they affect the body in different ways. But having a pressor when they don't respond to fluid could be really, really valuable. So that's management. So we've assessed our patient. We're treating them now. We get to the ER. We can drop them off, and they can continue the care there.
That's right.
Don't forget the value of the end-tidal.
Huge. Shock index. Yep.
The other, we didn't mention this actually, the ROX score.
Oh, yeah.
ROX.
Yeah, you were telling me about it earlier.
It uses the oxygen saturation and the FiO2, and then divide that by the respiratory rate. And if it's less than 10, then...
Tell them how to figure out the FiO2 pre-hospital.
Oh, yeah. So FiO2, so if you're bleeding...
If you're bleeding 12 times a minute.
So 5 liters nasal cannula. I think the study I read, it even had up to 6, but let's just say 5. You're getting up there, I think, to about an FiO2 of about 40, 45. If you use a non-rebreather, you can get your FiO2 all the way up to 95. Not quite to 100, but pretty high. So nasal cannula, think about it, can maybe get up to 50%-ish. And then, and by the way, room air, we're 21%. So nasal cannula adds, so a 5 liters equivalent to about 40, and then a non-rebreather, bag valve mask type situation, non-rebreather, 100%. just oxygen goes.
Right.
You get close to 100%, about an FiO2 of about 95.
Yeah, you're losing a little bit.
That's correct.
Yeah.
So I think that these are the types of tools that can help us assess patients better.
Mm-hmm.
And then we got the treatments. Mm-hmm. Hopefully IV antibiotics. Hopefully data will come out and prove me right.
Right.
But I'm betting the farm on the fact that early treatment in the right patient population, the sickest ones, will improve mortality.
Yeah.
Based on what we've read, by decreasing, we can increase mortality rate by delaying an hour.
That's right.
So what's the future? What is the future? This is exciting to me.
This is the data stuff.
Yeah.
Yeah. They're looking at these outcomes.
Yeah, AI.
Yeah.
So get this, Matt. Imagine the time when you would be
Never seen somebody get so excited about AI before.
Oh, it's
Your
really
face
cool.
just lit up. You're so excited.
I am excited about this because this is going to, I think, change a lot of what we do.
Uh-huh.
Is wirelessly we can be hooked up to huge databases where we plug in our patient's data, and then we can then correlate that data with our patient to millions of other patients who've been kind of put into buckets for sepsis. So we can identify now a septic patient based on historical data, millions of pieces of data, where we can add more accurately and live, real time, based on data and based on patient demographics, put them in a more accurate bucket of sepsis potentially. So I think, and it's not necessarily something where you're like going through SIRS criteria, but it's more of something where the data is entered into some sort of an algorithm in cyberspace somewhere, where
in the
real
cloud.
time, in the cloud basically, real time getting feedback on the risk of your patient.
Right.
I mean, that's very exciting to me. Less thinking, that concerns me a little bit.
Right.
Relying on a computer somewhere.
Right.
But that AI integration for sepsis screening, I think, is a huge deal.
Well, it's kind of like we're using AI to look at 12 leads now.
Yeah.
To pick up patterns that we might miss. And so I think it's a conjunction of using, our experience and our knowledge level in conjunction with these tools, these AI type tools, to help us be a little bit more accurate in our diagnosis on patients. Yeah.
Then there's also the analytics on the back end, and I think in looking at our accuracy. How well are we doing?
Right.
It's sometimes, I feel like it's a bit of navel gazing in the fire department where we look at the patients that we've identified and we say, hey, wow, 100% of the sepsis patients we treated last month got fluids within X amount of minutes or whatever it was. Or they got fluids, or maybe you're doing antibiotics and all your patients that you identified as sepsis patients got antibiotics.
Right.
But what about the ones you missed?
Yeah.
Well, I don't know. Who did we miss?
Yeah.
Show me.
Yeah.
Well, look at the hospital data. Those outcome data, that outcome data can give you a real accurate idea of how many patients you actually missed potentially. Or maybe you didn't miss any. Maybe you really are really good.
Yeah.
But you don't know if you're really good unless you've really looking at the discharge diagnosis of a patient that you brought to the hospital.
Right, that you called a stroke and it actually turned out to be a septic patient.
Exactly.
Right, and they're looking at the vital signs and all the stuff pre-hospitally. Oh, hey, you missed a shock index of 1.2 or whatever.
Right.
You missed that. You missed, they had altered mental status and low O2 stats and an end-tidal of 15 for 20 minutes. And you called that whatever. Right, a stroke patient.
Exactly.
This was like textbook sepsis.
And like we talked about earlier, it's all of us, regardless of our level of care, whether you're an experienced ER doctor or a new EMT. It's easy to diagnose something and then anchor on it.
Yes.
And that's how we miss things.
Yeah, bouncing down the road, your patient screaming at you.
I've told this to you before, but what is the most commonly missed diagnosis? It's the second one.
Oh, yeah.
Because we get stuck on the first one.
That's right.
And we miss the second one.
Yep.
And the second one could be the most life-threatening, or the third, like a story I told.
Yeah.
So I think that's a big part of what analytics can do, is to kind of eliminate that
anchoring a human
potential
element where we have a tendency to get biased because we're like, oh, this is this patient, this is what it is, and then we're missing the complete and obvious glaring signs of, nope, it's actually this, bro. Pay attention.
That's
and we're all
absolutely
guilty of that, right?
Yep.
Right, we're human.
And then a cool part about the outcomes is that we can then see where we really are.
That's right.
Yeah,
I think exactly. Yeah, you thought you were really good at this, and actually you suck.
Right. And I think most based on the data that I've seen, is that we're not as good as we think we are.
Right.
And I think that we're fooling ourselves if we can look at a 100% number in compliance with some benchmark for our, what do they call it? Those mission lifeline things, and our own internal kind of QI, QA of our own data,
right.
we can pat ourselves on the back, say we're doing a really good job, but we got to really look beyond that, I think. And that's where I think the future of our whole field is going. We're going to be more accountability now by looking at the right outcome measures, and we're going to see, wow, we really matter what we do. I think that's
things. And things are going to change, right? Sepsis care is going to change. It's going to evolve, right? So what we're doing today probably isn't going to be what we're doing in 2 years. So, why are we doing that? It's because they're looking at all the data, right? And we're trying to improve patient outcomes at the end of the day.
Well, it's going to tick off a lot of hospital executives and doctors when I say this, but I've always believed this. In my time working with payers and government agencies and hospitals all over the country, I really believe that the hospitals should only be ICU and ER. The sickest people that need care, they're the ones that should be in the hospital. Most of the people in the hospital really shouldn't be there, either getting home care or some outpatient care or something that's far less expensive.
But they make money off of it.
I know. And that's kind of the way we've always done things.
Right, sure.
And people don't like change.
Right.
And it's interesting, I read recently that there's a company that's actually trying to develop mobile ICU medicine so they can set your house up, a room as an ICU. Wow. I mean, that's crazy. I could tell you lots of stories about reform within healthcare and all these different reimbursement models. But the point is...
That's a whole separate podcast.
It is a whole separate podcast. But the point is, though, is that what we're doing in this pre-hospital environment with patient identification, sepsis is a great example, is we have a lot to say about the most expensive thing the hospital does and kills more people in the hospital than anything else.
That's right.
We have a hand in that, and we can do a much better job. So I think sepsis is a really a
hot
fruitful topic.
Yeah, and one that's, like I say, it's evolving and changing. So stay up with the research and the data, and stay on top of it because it's important stuff.
Ask questions. If you like, there's a way. You're working in some agency somewhere. Is there a way we can make our sepsis protocols better so we can identify more patients? Or how many are we missing? Ask them. If you don't know,
start with your medical director.
Right.
Talk to your medical director and see where they're at, and then do your due diligence online. Like you're doing by listening to this podcast, right?
That's really good.
If you're not doing these things, you probably should. So, see you on the next one.
Be safe out there.
Thank you for listening to EMS, the Erik and Matt Show.